Chairman. I appreciate the fact that our oversight so far, and we have sent a lot of letters and done a lot of interviews, that oversight has been not just bipartisan, but nonpartisan, and that we have been able to set aside politics and focus on the facts and past events, but also on the road ahead of us, and how we can learn from what happened during this unprecedented, tragic coronavirus situation. First, though, I want to take a moment to acknowledge the extraordinary loss that our nation has experienced. As of this morning, 559,741 Americans have died because of COVID-19. And like just about all Americans, I've lost friends. I've also lost former staff members, and we all join with the families in grieving those we have lost during this pandemic. I also want to express my gratitude for the work and the sacrifice of those who have been on the front lines, particularly those healthcare professionals who have been out there on the front lines for all of us, 1,541 of whom died fighting this pandemic. So COVID-19 has been catastrophic. There's no mistake about that. It also presented an unprecedented challenge to, and in many ways, an unprepared U.S. public health system. Why were we unprepared is one of the questions we'll get into today. Unlike emergencies more localized in nature, a pandemic is not a singular event. COVID-19 has stretched across our entire country, in fact, the entire globe, with no regard for borders or beliefs. The scope is unprecedented. It has stressed our supply and healthcare systems, including our critical frontline personnel, as we said, and stressed it often to a breaking point. And we have seen the economic damage. Millions have lost their jobs as a result of pandemic restrictions. We're here today to understand some important issues. The United States preparedness and initial efforts leading into the COVID-19 pandemic, the initial federal response, and to identify recommendations to improve federal preparedness for future pandemics and other public health threats. We owe it to those Americans who did die as a result of COVID-19, to their families and countless others who are struggling to make ends meet, to make this a serious, nonpartisan oversight effort. Looking at the steps the federal government took in the initial days of the pandemic, we got to learn from the experience for the future. To that end, I think there are three issues important to address. First, CDC surveillance systems and the lack of testing limited our early response. We know that China irresponsibly downplayed the initial severity of COVID-19. In my view, there's no question about that. That presents questions about our ability to work with global partners, particularly China, to identify and combat pandemics in their nascent stages. But how did we do in the United States at recognizing and communicating COVID-19 cases, symptoms, and deaths once the pandemic reached our shores? The CDC can only communicate and address the issues it knows about and understands. In many instances, what we found out is that COVID-19 cases manifested in patient symptoms and were ultimately the cause of death. That information was slow to reach the CDC. Why was that? Instead of seeing real-time data, CDC was only seeing fragmented historical data. Adding to surveillance challenges, diagnostic testing was slow to develop and then slow to scale up to the level required by the pandemic. Why was that? It's critical that we enable state and local public health officials to communicate effectively and directly to the CDC. We also must have the capability to scale up testing when needed. We know those things. We've got to talk about how we can do that better. In a future pandemic, this could mean the difference between quick life-saving decisions or confusion and the needless loss of life. Second, who was in charge? Where was the accountability? This is something I look forward to asking some of our distinguished panel about today, because they've had a lot of experience in how these things are managed. A recurring narrative in interviews with former government officials, like the ones we have today, and public health professionals, is that in the initial stages of the pandemic, leadership roles were not well defined. And they still are not well defined, in my view, in some respects. This resulted in confusion at the federal, state, and the local level, and likely slowed our initial response considerably. But we knew this was going to be an issue. In 2019, HHS ran an influenza pandemic tabletop exercise called Crimson Contagion. That exercise identified the lack of defined leadership as a major challenge. The exercise found that insufficient and conflicting statutory authorities defining leadership roles hampered the federal government's ability to effectively respond to a pandemic. Confusion about leadership was also an issue identified following the 2009-2010 H1N1 pandemic. So this should be a cautionary tale for us as we continue our review. It's not enough to identify issues. We've got to be forward thinking and actually implement solutions to the issues we discover. Third, this unprecedented pandemic crippled the US medical supply chain in the initial weeks of the pandemic. Why was that? It was due in large part to the longstanding over-reliance on China for pharmaceuticals and other medical supplies, including PPE. Reports indicate that China, as early as December 2019, increased imports and decreased exports of medical supplies as their own needs increased, dramatically shrinking US purchasing ability. Compounding this issue was the lack of an organic medical supply stockpile here in our country. The Strategic National Stockpile, SNS, which we'll talk about a lot today, the largest federal repository of pharmaceuticals and critical metal supplies available for rapid delivery to support the response to a public health emergency, was not adequate when those state and local supplies are depleted. And it was frankly understocked. We need to talk about why, and again, how to prepare for the future. The SNS was never replenished despite urgent requests after the 2009 H1N1 pandemic, and further, it was never meant for a nationwide response. This too was an issue we knew about. Past pandemic exercises and lessons learned from prior pandemics, such as H1N1, told us that the supply chain resiliency was an issue. Now let's consider this: a critical supply chain with a single point of failure, a strategic national stockpile that was never meant for a national response. I understand the supply chain has mostly recovered and the stockpile is restocking, but we can't allow these issues to impede a further pandemic response. So the tragic loss of life, the devastating impacts on the economy and American workers, and also the destabilizing effect on global stability and security has taken a toll on all of us and all nations. Given the extent of existing issues within the public health system I just discussed, it's little surprised that the initial pandemic response was chaotic and unorganized. Again, as chairman, I appreciate the nonpartisan nature of this review so far, and I stress the importance of identifying a bipartisan way forward. We've got to figure out how to come together, learn from these lessons, and be better prepared next time. I thank our witnesses for being here today. I look forward to hearing from them and look forward to hearing on their thoughts on the way forward.